Good morning, everyone. I am so very pleased and honored to introduce today's Grand Round speaker, Dr. Diego Chavez Hineko. While Diego did not do his medical school here, having graduated from Pontificia Universidad Javeriana in Colombia, he did begin to become a University of Pittsburgh Children's Hospital lifer by doing his pediatric residency here at Children's Hospital, where he joined CORE, our community-oriented residency education program. As you will hear today, he has continued his dedication to community outreach and empowerment ever since. He obtained his master's in public health at the University of Pittsburgh Graduate School of Public Health. Diego then completed his fellowship in developmental and behavioral pediatrics in 2008 and was a fellow in the Maternal and Child Health Bureau program and a fellow as well in leadership, education, and neurodevelopmental and related disabilities, also known as LEND. And then he fully graduated to children's lifer status by becoming faculty in the Division of General Academic Peds. In the summer of 2002, as part of his core training, Diego created the first pediatric bilingual bicultural clinic in southwestern Pennsylvania. Since its creation, this clinic has been expanded to the program Salud Para Ninos, Health for the Children. At Salud Para Ninos, culturally and linguistically competent primary care for children and families is complemented with activities oriented towards prevention, and very critically towards empowering the community about its own health. Diego, however, was not content to simply ask families to come once a week to see him at primary care clinic in Oakland. He recognized that there are issues of access in the community, and he has worked to extend care to our Latinx population by opening a monthly free clinic at the Birmingham Towers, and also sees patients on UPMC Children's Care Mobile, as well as in Casa San Jose. It is no surprise, of course, then, that Diego's tireless dedication has been acknowledged by numerous awards. The list is long, and so I only have time to highlight a few. So we'll start all the way back in 1987 when he was awarded the Andres Bellos Medal from the Ministry of Education in Colombia. And we'll jump past many other honors to 2012 when Diego then received the Chancellor's Distinguished Public Service Award from the University of Pittsburgh. And then in 2019, the incredible honor of being awarded Pediatrician of the Year by the American Academy of Pediatrics Pennsylvania chapter. It has now been an amazing 20 years since Diego started his journey of dedicated holistic care to the community. And we are so very fortunate to be able to hear today about the accomplishments along the way. I give you Dr. Diego Chavez Hineko.
Thank you very much, Loretta. It's a true honor to be presenting here at Grand Rounds, and in particular to have that introduction done by our Vice Chair of Diversity and Inclusion. I remember when we started the program 20 years ago, Dr. Mateo joined us in our church to start the adolescent clinic for the Latino community. At that time was Dr. Mateo and Dr. Murray, and that was continued by many others, and currently led by Dr. Miller and by Dr. Orquídea Torres. So I'm gonna start sharing my slides, and I'm going to tell you about what had been the story of our program over the last 20 years. So Salud Para Ninos are the three words in Spanish for health for the children. And actually Salud is an acronym that stands for students, residents, faculty, and Latinos United Against Health Disparity. I add every time on my training and my career another word. We start with the students, then residents, then fellows, and then faculty, and obviously all the time united with Latinos Against Health Disparities. That's one of the main goals of our program. So today, we're gonna be talking about who are and what are Latinos. And throughout the presentation, you're gonna see that I use interchangeable words like Latinx or Latinos. I'll explain a little bit more about that in a minute. We're gonna talk about demographics of the population in the world, at the national level, and at the regional level. We're going to talk about special characteristics of the community, and then we're going to focus on barriers to healthcare access and how, if we don't address these barriers to healthcare access, we're going to have health disparities. And perhaps one of the biggest health disparities that we have seen in recent years is the COVID-19 pandemic. After that, we're going to specifically talk about our program. We're going to talk about our program aims and how through the methods of our program, we're going to try to address those barriers and disparities in our community. And finally, I'm going to share some results and conclusions with all of you. So let's start to define what are Latinos. In this slide, you see a lot of diversity. You see a lot of racial diversity because Latinos can be white, Latinos can be Black, Latinos can be Asian. So Latinos is an ethnicity. And again, I'm gonna expand more in this concept in a few minutes. The other thing that you see in this slide is diversity in terms of professions instead of careers. Latinos have a long-standing history of contributions in this country and worldwide. From medicine, you have here two of the many Nobel Prize in medicine that are Latinos, Dr. Becerra from Venezuela and Dr. Severo Ochoa from Spain. You also have Carlos Finlay, who described the yellow fever transmission. And then also you have many other careers, many other areas in sports, our Roberto Clemente in entertainment, and most recently, of course, Lin-Manuel Miranda, and one of my beloved movies, Encanto. If you haven't watched it, I encourage you to watch it. As a matter of fact, if you look at Encanto, one of the biggest hits of Encanto is to portray this diversity that I just described. All the characters have different races while they join the same cultural traits, the same ethnicity. So what are Latinos? So Hispanic Americans, Latino Americans are the words that come from this word derivates, are Americans from Latin America, from Spain, and from Portugal in the United States. As a matter of fact, these terms of Latinos or Hispanics is not that used abroad. It is very common here in the United States to refer ourselves as Latinos, but if you go to Latin America and you ask somebody what is your ethnicity or what is your background, they might refer by their country of origin. I'm Colombian, I'm Mexican, but they might not use the term Latinos because this is a very unique term that we use here in the United States. An important piece in terms of this is that it's by self-identification, and nobody can prove you wrong. So it's whatever you decide to use, whatever you decide to identify. And you can be fully Latino or partial Latino, although somebody was telling me there is no such a thing as being half Latino. You're full Latino and full American at the same time. And as I was mentioned before, the importance that we share some common cultural traits, common ethnicity, where is language, where is other cultural traits. When do you use the term Hispanic or Latinos? And again, it's by self-preference, it's by self-definition. And then the term Latinx versus Latinos. The issue with Latinos is that in Spanish, we use different genders, different vocals for the gender. So the O usually mean men, male. The A usually mean women. So in recent years, there has been a movement to change Latinos to Latinx to be more inclusive, include men, women, LGBT, transgender, etc. Most recently, actually, I saw somebody who was using Latine, using the letter E at the end, again, to make it more neutral. But again, it's by self-definition, it's whatever you feel more comfortable. In terms of the terms Hispanics versus Latinos, Hispanic originally denoted the relationship to an Asian Hispania on a Spanish language, while Latino, some people consider that is more inclusive because it includes not only people who speak Spanish and other countries of Latin America, but also those who are Portuguese speaking, people from Brazil, from Portugal. So here are some numbers. These are the countries around the world where Spanish is spoken. Of course, the Americas, Europe, Africa, and as a matter of fact, I was surprised that recently I saw a patient from Africa whose native language was Spanish. The baby was born here in Pittsburgh, and she's one of our patients in Salud Para Ninos. And then the total population of people who speak Spanish around the world is close to 543 million. And then you have the different countries where Spanish is spoken, being Mexico the first country, Colombia the second one, but right there in third place is the United States. Now, in terms of Portuguese, it's spoken as well in the Americas, mainly in Brazil, but also in Africa and countries like Angola, Mozambique, and of course in Portugal. And then there are over 274 million people who speak Portuguese in the world. Just as a note, if you are using the Siracom interpreter system, if you ask for Portuguese, you're gonna have an interpreter who is fluent in the Portuguese, who is from Portugal. If you wanna use it with a family who come from Brazil, you wanna ask for Brazilian Portuguese. There are some subtleties between the two languages. They can understand each other, but of course, if you can choose the best one, the best fit, better. Now, let's focus in our country. So this is from the census of 2020. As many of you know, every 10 years, the federal government goes through these surveys, and this is how we know how many people are in this country. So we have these demographic pyramids, and in the x-axis, we have the percentage of the Latino population versus the percentage of the non-Latino white population. And then in the y-axis, you have ages. And here in the main population, you have the baby boomers that now they're reaching their 50s, 60s, and 70s. A lot of these people are the ones who are retiring now these days, and this has contributed to the difficulty on filling jobs in this country during this pandemic. And then the other point that I like to make when I show this is that if you look, the thick of the demographic pyramid in the Latino population, it's under the population under the age of 18. 1/3 of the Latino population is under the age of 18, compared to the general population where only 1/4 of the population is under the age of 18. So the Latino community, the Latino population tends to be a younger population. This has to do for many reasons. We have higher natality rates, and also the fact that you tend to migrate, to immigrate if you're younger. And of course, one of the ways to think about this is that this is the workforce who is supporting the rest of the pyramid, and this part and definitely is going to help in general for the entire community. This could be controversial. Some people might disagree with this, but this is one of the things that we see with this. So it's about 62 million of Latinos in the US, about 18% of the population as 2020, the census of 2020. Now, some characteristics of the Latino in the US: 70% are citizens, 89% of the children of the Latino children are born in the US, 52% are second generation, 37% are third generation. 77% speak Spanish, and 62% also speak English. Now, when you look at the population who are 25 years and older, at least 75% of them have a high school degree. 50% are homeowners. And then I was looking at this data and I saw different numbers, anywhere between 16 to 19 million people, Latino votes in 2020. This number varies from election to election. And there is an approximation that about 25 million of Latinos are US citizens, and therefore they are eligible to vote. Now, of course, there might be other US citizens who are under the age of 18 who are not eligible to vote, which is the biggest group, the pediatric population. Now, focusing in our state, and I like this slide for many reasons. Now, give us some information on our state, but also help me to make the example of the difference between ethnicity and race. A lot of people use these terms interchangeable, race or ethnicity, but they are not the same. As I was mentioning before, being Latino, being Latinx is a cultural trait. We share some cultural traits, whether it's the language or other cultural elements, but that doesn't mean that we have the same race. So you can be Latino and white, you can be Latino and Black, you can be Latino and American Indian, you can be Latino and Asian. And then what I was mentioning before, this is by cell definition. So in the state of Pennsylvania, we are about 13 million people, and out of those 13 million people, about 1 million are Latinos, we're Latinos. And this is 8% of the population with this ethnicity. And this is an increase from the previous census where we were at 6%, so the population continued increasing in our state. Another point that I want to make about this, in a few slides, I'm going to be talking about health disparities and how the COVID-19 is one of the biggest disparities that we're seeing in our community, and how this was in many cases led by the lack of information. So for many years, now 2 years into this pandemic, you saw the press releases from Governor Wolf, from our former health department director, Dr. Rachel Levine, here locally from our beloved Dr. Deb Bogan, giving these press releases in English, and simultaneously, they are being interpreted in sign language for the deaf community. So it turns out that the deaf community in the state of Pennsylvania is the same number of the Latino community, which is 8%. However, to this date, you don't see any of those press releases simultaneously with closed captions in Spanish or translating to Spanish. And that's one of the things that have contributed to the disparities in the COVID-19 pandemic, the lack of information. Now, in our area in Southwestern Pennsylvania, when we look at the 7-county area, counties like Allegheny, Beaver, Butler, Fayette, Greene, Washington, and Westmoreland, we can also document a tremendous increase in the growth of the Latino population. And in particular, this is important because, as many of you know, for many years, Southwestern Pennsylvania was a region where the general population was decreasing in numbers. So while the general population was decreasing, the Latino population continued to increase. So back in 1990, we were about 11,000. By 2000, we were close to 17,000. And by 2020, we're 45,000, so we're 45,000. So in the last 20 years since the creation of our program, we went from 17,000 to over 45,000 Latinos in the region. There's almost 3 times the population has triplicated in that period of time. And that's true as well for the pediatric population. We know now that in Southwestern Pennsylvania, we have about 15,000 children under the age of 18, and that's the focus of the populations of our work. Of course, their families too. This was done many years ago by, at that time, 2 medical students, Arturo Torres. What they did is that they plot the zip codes of the patients who come to our clinics. And one of the things that is characteristic for our community here in Southwestern Pennsylvania, in Allegheny County, and in Pittsburgh, is that they don't live in the same neighborhood. There are areas that are growing a lot, like Beachview, Brookline, and that's where we have focused our work. But also, we have families who come from all over around the place, from the North Hills, from the South Hills, from Monroeville. So in brown, you see the zip codes where the family come from, and in blue, the places where we're trying to provide our care, of course, in our main hospital in Lawrenceville, in our primary care center in Oakland, and through our mobile unit in the South Side and in the neighborhood of Beachview. Another unique characteristic of our community locally is that the country of origin varies. So when you look at the entire population of the United States, the majority of Latinos self-identifies as either Mexican Americans, Puerto Rican Americans, or Cuban Americans. In Southwestern Pennsylvania had been very interesting that back in the 1990 and 2000, the majority were South and Central Americans. So very different than we were seeing at the rest of the country. By 2010, the majority were Mexican Americans, which still was very interesting because it was very different to what we were seeing at the rest of the state. In places like Harrisburg, Allentown, Philadelphia, the majority are Puerto Rican Americans. We're still looking at the numbers from 2020, but it's a very diverse population what we have in our area. We have people coming from South and Central America. We have definitely Puerto Rican Americans, and we have, of course, Mexican Americans. The other very interesting characteristic of our community is that there is a disproportion between education and income. The Latino population in Southwestern Pennsylvania tend to have more years of education than the general population, with graduate students, master's degrees, doctorate degrees. However, despite these many years of education, the income of the population is very similar to the income of other Latino populations around the country, which, by the way, is below the income of the general population. So there is a disproportion between education and income. Now let's talk about barriers to healthcare access. So there are many barriers to healthcare access, and this is from Dr. Glenn Flores on an article in the New England Journal of Medicine back in 2006. And he was talking in general that children in the United States, 1 in 15 children in the United States, ages 5 to 17, grow in a household with limited English. This is not only about Spanish speaking, but other languages that are spoken at home. So definitely language is a barrier. When you cannot speak the same language of your healthcare provider or your physician, that's going to be a barrier. There are also cultural aspects, and where you might speak the same language, you might not share the same cultural traits. And actually, for me, this has been a learning experience. While I'm Latino, I'm Hispanic, I'm Colombian, I had to learn for the last 20 years, many of the different characteristics that different subgroups have, like the Mexican American community, the Puerto Rican American community, the Salvadorian community. Insurance could be also an issue, and it's not only where you are insured or not insured, but also underinsured. In our department, there was recently a very important publication about underinsurance status. We have many families who come to our free clinic, not because they don't have completely lack of health insurance, but because they have this type of health insurance that only may cover emergency situations. So they don't have coverage for primary care, for preventive care, for immunizations, and vice versa. We have families who might have preventive care coverage, but they don't have emergency care. And that's why our free clinic provide care for these families. Of course, socioeconomic status, transportation, and immigration status. And when you talk about immigration status, is again not black and white. Is not whether you're documented or undocumented in this country, but you can be fully documented in this country, and still you might not be able to qualify for federal or state health insurance funded programs. When I talk about this, I always tell the story that happened about 10 years ago. There was a family of 2 doctors. The dad came to Pittsburgh to be trained in transplant medicine at UPMC. They have 3 kids. They were fully documented. They were either on a student visa or on a work visa, but because they were not citizens, they couldn't have the kids enroll in programs like Medicaid, CHIP, or any other type of insurance. The only option that they have for their kids for health insurance was to purchase commercial insurance through their work. And unfortunately, as many of you know, the salaries of fellows and residents is very limited, and they had 3 kids. They couldn't afford to buy health insurance for those 3 kids at the beginning of their training. So for a few months, maybe for the first year, they came to our free clinic. Once things got a little bit better, they were able to purchase commercial insurance, and we were still being able to see them in our Oakland clinic. And then I put as a last point other, and is that this is a dynamic process. After 20 years of doing this work, I am still learning of many barriers that family have to have access to healthcare access, and that might result in disparities. So if we don't address these barriers to healthcare access, they become disparities. And again, Dr. Glenn Flores illustrating this article in the Journal of Pediatrics, how these barriers can be arranged by either system, whether it's access to healthcare, likelihood of regular source of care, continuity of care, immunization rates, where is barriers to communication doctor-patient, adherence to treatment in patients, health status, use of harmful remedies, adequacy of analgesia. I believe there was one of our former fellows who did a study on disparities of use of analgesia in minorities, preventive screening, and prescription practices. And then again, if we don't address this becoming many disparities, and this is just an example of some of the disparities. So when you compare Latinos versus non-Latinos, white children, 30% of Latinos don't have usual source of health care versus 16% of non-Latinos. 22% of Latinos are uninsured children. And what we have known from the publication, from the literature, is that many Latino children don't have access to health insurances because some of them don't qualify and they will never qualify, but other ones, and actually I want to make a point about that, they don't qualify right now in Pennsylvania. In Pennsylvania, we are behind in this. There are other states that have true universal health care for all children, regardless of immigration status. States like New York, Illinois, California, Massachusetts, they have true universal health care for all children in their state, regardless of immigration status. So there is a movement here led by many to make sure that we have true universal health care for our kids. It's about 24,000 children in the state of Pennsylvania who don't have who won't qualify to health insurance. So that is going to be part of the problem. The other problem that we have in terms of uninsured Latino children is that many of these families don't know that they qualify for health insurance. There are barriers to access the health insurance because of language. When I started the program as an intern 20 years ago, I went through the process. I didn't have kids at that time, but I went through the imaginative process of if I had to apply for Medicaid. And I realized that it was a very complicated process, like almost making your taxes. Sometimes the forms are not available in the language that you speak. So there are many barriers to apply for this. And unfortunately, the last 4 to 5 years with the previous federal administration, there were many more other barriers to put to families. And many families actually, even though they had health insurance, they decided to drop the health insurance because of concerns of retributions. I remember a family, an example of this, there was a family who were not Latinos. They were, I believe, from India. They had been in Pittsburgh for several years. Their parents were either faculty or in academic careers. And then for many years, the girl was born in Pittsburgh, and for many years, they took the girl to SHIA, to the Shadyside Family Medicine Clinic. But once these rules were enacted by the previous federal government about the possibility of this being affected, the path for citizenship, the family decided to drop the health insurance. So they started coming to our free clinic. So over the last 4 to 5 years, we have seen a huge increase on insuring children in our region. And of course, the demand for our services has increased. And I'm going to speak more about this in a few slides and tell you how we have tried to address this problem. There's also disparities in terms of treatment for preventive care. There was a study that documented prescription of preventive asthma medication after being hospitalized. Only 2% of Latino kids were in this group versus 21% of non-Latino kids. Obesity is a big problem in our community. 39% of Latino population are obese versus 29% of non-Latino children. And then autism is one that is very close to my heart because of my other hat. I'm a developmental behavioral pediatrician. Latinos tend to be less likely to be diagnosed with autism. And there are many theories about this. Some people talk about the possibility of this being genetic. Some people talk about the cultural traits of the community. I'm going to speak a little bit more in the next slide about this. But one other concern that we have, and that probably is one of the reasons, is that there is lack of awareness about autism and services for the Latino community. So as many of you know, it's hard around these days to get an evaluation for autism for the general community. To get an evaluation for autism for many in the Latino community is even much more difficult. And then there is this misconception, and I try to teach my residents and my students that if you grow in a bilingual home, that's okay to have some language delay. Please, that's never okay. So if you have a child with language delay, if they're growing in a bilingual home, that's not the reason for the language delay. They need to be referred, and this one of the reasons could be autism. So I was talking about cultural traits of our community, and even though this is an old slide, I like it, and I thought it was also relevant because the first thing that I talk here is about resilience. And what more to talk about resilience in the Latino community during the COVID-19 pandemic is the capacity to recover quickly from difficulties and that show toughness. And again, I'm going to illustrate this when we talk about the COVID-19 pandemic. When you compare the Latino culture versus the mainstream culture, the Latino culture is more focused on cooperation versus competition. There is emphasis on interpersonal relations versus emphasis on task orientation. There is collective orientation versus individual orientation. And then the Latino families tend to live in extended families. Again, another reference to the movie Encanto, where you see that the kids are being raised by aunts, uncles, grandparents, versus what we have in the mainstream culture, which is the nuclear family, mom, dad, and the child. And then some of the authors talk that the fact that the Latino families raise their kids in extended family systems, that might be one of the protector factors against autism. So maybe the reason that we have less diagnosis of autism in our community is a combination of all the reasons that I have mentioned, but one of them could be the family support. So let's talk about Latinos and COVID. As many of you have seen in the news and in different publications, Latinos are 3 times as likely to contract COVID, twice as likely to die from COVID. They have a high risk to contracting COVID in the Latinos communities, high risk for social determinants effects that actually, predispose to contract COVID, but also to address the issues once the COVID is contracted, higher mortality in Latino communities. While we are only 18% of the population nationwide, we represent 27% of all COVID-19 deaths. And in some regions, this is even worse. In New York City, 29% of the population is Latino, but 39% of all COVID deaths were attributed to the Latino community. So here are some information from the CDC. I actually got this one yesterday. And as of yesterday, there were 24% of all the cases of COVID-19 in our country were attributed in the Latino community versus 75%. Now, one of the problems that we have with disparities is that we don't have all the information in terms of race or ethnicity for cases. This is true at the local level, at the state level, at the national level. So there is all this data collected, but only 65% of the cases they have information available in terms of race and ethnicity. The same is illustrated here, and here you more clearly see the disproportion. In gray, in the gray bar, you see the representation of the subgroup in the general population. So I mentioned before, Latinos were about 18% of the population. And in burgundy and brown, you see the number of cases. So there is overrepresentation of the Latino population in terms of cases compared to representation in the general population. So this is a huge disparity. In Allegheny County, this is again from yesterday, we see that the population is about 2.3% of the population. The number of individual tests and infections are around the same, 2.4, a little bit over the 2.3% of the population. But where you see the huge disparities in terms of hospitalizations, so more complications, 4.1, and in terms of deaths, 2.5%. So more deaths, more hospitalization in the Latino community compared to the general community in terms of the representation in the larger community. So why are Latinos more vulnerable, more at risk for COVID and for COVID complications? One of the things is that we have higher numbers of essential jobs, whether it's healthcare, doctors like me, whether it's in the service industry, food services, construction. There is high risk of physical contact. At the beginning of the pandemic, many of the members of the community were asked to stay at home, but for many of the Latino members of the community, that was not an option, either because of the type of job that they did, whether it was in healthcare or other services, transportation, and also because many of them depended on their job to have an income. And by the way, many of the Latino members of the Latino community didn't qualify for the federal stimuli. I'm going to talk about that in a minute. So they didn't have any option just to go to work. And there is also a problem of less access to healthcare. And I have talked already about this. I was talking about, in particular, children, but in general, 49% of Latinos have health insurance, so 51% are uninsured. And then of all the 49%, there is a large proportion who are underinsured. And when you have health insurance, you're going to have less access to preventive care. And if you have less access to preventive care, you have higher risk of chronic conditions such as diabetes and obesity. And with these conditions, including things like hypertension, cardiovascular conditions, if you don't have access to healthcare, they're going to be well managed. And of course, we know now, this after 2 years of the pandemic, that if you have these conditions, and if these conditions they are not under control, you're at higher risk for poor outcomes with COVID, meaning hospitalizations and death. And then lastly, but not less important, the lack of information about COVID. I mentioned before how for many months, and even up to today, there is a lack of reliable information in our communities that is available in the native language of the different communities that we serve. This is a slide that mentioned representative from Texas, Veronica Escobar. She was quoting Dr. Fauci, and she was talking about the vulnerability of minority communities, including Latino communities, that it was the same that you see in nursing homes. And therefore, through the pandemic, the recommendation was that our minority communities were addressed the same way that these vulnerable communities were being addressed in terms of testing, tracing, and then later on with immunizations. An important piece, the increased availability of information and of course, advocacy for these groups. I was mentioning before this is not specific about Latinos, this is about immigrants. This is from the Immigration Policy Institute that talks about how the CARES Act, the federal pandemic stimulus checks, didn't reach many in our community. 15.4 million of people were in mixed status families, meaning that maybe one of the parents was a citizen, the other parent was not, and therefore they were excluded from the stimulus package. 9.9 million were unauthorized immigrants, 3.7 million of children who were US citizens or green card holders were excluded because maybe one of the parents was not a citizen. 1.7 million of spouses who were US citizens also were excluded because their spouses might have not been US citizens or green card holders. 5.5 million of US citizens and green card holders were excluded from this relief. So when they didn't have this relief, the only option that they had was to go to work. And then of course, the risk of contracting the disease and how the complications were higher. So this is from Brigham and Women's Hospital, and they specifically talk about racial disparities and COVID. They talk about exposure risk at work, exposure risk of public transportation, exposure risk in the shared living spaces, comorbid health conditions, I already mentioned, hypertension, obesity, diabetes, access to healthcare and testing. And then specifically, they use the word racism in healthcare delivery. And then of course, chronic stress. Many of our families have been suffering chronic stress for many reasons. Many of them immigrate because of chronic stress, because of trauma in their country of origins, because of violence, because of lack of social and financial support. In the case of Puerto Rico, many of the families migrated because of the hurricanes, and then they come to this country, and then the pandemic hits. So they were double traumatized, they were subjected to double stress. And of course, that didn't help in many ways. So again, from Brigham and Harvard, they propose how to address these issues. And one of the things is that to collect transparent data, things like age, sex, race, and ethnicity, primary language. I already showed you how to this day, 2 years into the pandemic, we don't have enough information about race and ethnicity in terms of cases, mortality, about COVID-19. This is true at the national level, at the state level, at the local level. They also encourage to document socioeconomic status when we're caring for families. One of the ways to do this is by proxy, by zip codes. In our clinics, even before the pandemic, and at Children's Hospital of Pittsburgh, we have been screening for some determinants of social health, like food insecurity. As many of you know and witnessed with the pandemic, the need for example, for food support exploded. We were starting to provide groceries, both in the care mobile, in our mobile clinic, in our clinic in Oakland, something that we didn't see as much before the pandemic. They also advocate for the employer communications tool when there is limited English proficiency. Of course, the right type of tools, certified interpreters. Many states have laws against using family members as an interpreters. The idea is that we use certified interpreters and if we have maybe native speaking providers, but having a provider who might be fluent on the language might not be appropriate, or having a family member translate for the patient might not be appropriate. They also encourage to develop communications tool for patients with disabilities, the use of surgical masks with clear windows. And many of you have used and have seen this mask. And I will say this mask is not only good for people who have disabilities, but also for those of us who have English as a second language. People don't realize that, and actually we sometimes don't realize that, but people who have English as a second language, sometimes we read lips. It's a way to better understand what is happening. So using clear mask windows will help with taking care of our families who have English as a second language. Having pictures of the clinical team in the waiting room can alleviate the anxiety of the patients. And we do this, we have this in our waiting room area in Oakland. And then finally involves diverse personnel in developing clinical and ethical guidelines. I'm going to be talking about Salud Para Ninos in a few slides. In some point, we had as many as 8 bilingual staff, including patient representatives, nurses, medical assistants. We're now down to 2. By the way, let me help to advertise. We're trying to recruit patient representatives, nurses, medical assistants. It's not required, but ideal bilingual. So if any of you knows about somebody who would be interested in working with us, we're hiring, just let us know. And then I'm going to go very quickly to the next couple of slides, because these are recommendations that were made for everybody during the peak of the pandemic, and we still are valid, which is to recommend to avoid physical contact, not necessarily avoid social contact, but physical contact, physical distancing, recommend to have physical distancing. The reason that I decided to keep this slide is because some of these things were cultural traits of our community. In our community, it's very frequent that we do handshaking, hugs, kisses. This was a huge change in the way that we relate to each other in the Latino community. Also avoiding social events. People understood that this was not a good idea during the pandemic, but for some reason, some members of the community thought that it was okay to make exceptions when you had a quinceañera or graduation. So this was a big problem. And then also to avoid physical contact with family members. And, some people say, well, it's my family, but if they don't live in the same household, of course, that was not recommended. Now, when we were dealing with these situations, we have some special recommendations for the community. A lot of our family, a lot of the members of our community tend to travel. Religion is really important in our community for many. So attending to churches to these days, when I go to church, for example, we have to remind people to wear a face mask. It is really difficult. And then when we were making recommendations to have isolation at home or quarantine at home, it was really difficult because some of these families live in a single room. So how can you ask somebody to just use one room for the person who's sick and use another room for the rest of the family when they only have one room for everybody? So try to be creative, isolate in a corner of the room. If they only have one bathroom, try to clean the bathroom every time the person who's sick use the bathroom, etc. Now let's talk about Salud Para Ninos, health for the children. And again, Salud is the acronym for students, residents, fellows, faculty, and Latinos United Health Disparities. Our aims is basically that, to reduce barriers to healthcare access, and by reducing barriers to healthcare access, to reduce health disparities. We want to combat social isolation in the community. We want to partner with community agencies. We want to permit systematic data collection, and we want to create an ideal environment for developmental screening. So the clinic was created 20 years ago as a medical home for Latino children and families. It was the first bilingual, bicultural competent clinic, and we also serve Portuguese-speaking families, so I would say trilingual. And as a matter of fact, because of our free clinics, we have families who come to our clinics who are not necessarily Latino. We have families who come from places like Norway, South Korea, Japan, Indonesia, and it's very interesting how families learn about the service that we provide. But the Care Mobile is the only true free care in the region, and this is why many families who are even not Latinos come to our clinics. We're providing traditional primary care service at Children's and the Birmingham Clinic at Casa San Jose and through the Care Mobile. The idea is to increase prevention and empower the community to address its own health. So in Oakland, we have now three continuity clinics, three clinics for the community as part of Salud Para Ninos. On Tuesday afternoons, on Thursday mornings, and on Fridays mornings. It's staffed by Spanish-speaking physicians, by nurses and volunteers. And we were the first local Spanish line 20 years ago with the option 8 in Spanish. The 412-692-6000 is the phone number for our primary care. It works 24/7, and during the business hours, we have option 8 in Spanish, and we have our staff answering to this phone. And of course, right now we're in a busy time during the pandemic and with the short of staff, but we're trying our best to answer to all families. Now, we started the program in 2002, and our thought was that the majority of the kids had health insurance, and that is still true. But then we started to realize that some kids didn't have health insurance. And if we were seeing kids who didn't have health insurance in our primary care center in Oakland, they were getting bills for $200, $300 for a well-checked visit immunizations. And of course, families couldn't afford this. And that's when we started thinking about going to the Birmingham Clinic. So the Birmingham Clinic was created 4 years ago. It was initially created as a homeless clinic, and then it was through the initiative of some faculty from the University of Pittsburgh, and then slowly transferred to a clinic for uninsured people. And it was managed under the program from the underserved population from internal medicine. And internal medicine was the first specialty who provide care in this clinic. We as Salud Para Ninos and as Pediatrics, we were the second specialty. We reached to Birmingham Clinic and said, we want to come, we want to see kids. And they opened the door for us and they're welcome. And by the way, thank you to all the staff of the Birmingham Clinic for all their support over the last 18 years. The initial building is this one that you see here. It was in the south side. This building is now demolished. We had initially only the first floor, and the first floor had two tables, exam tables divided by this board. And then one of the exam tables was the adult clinic, and the other exam table was the pediatric clinic. And we did this for several months until we started bringing the Care Mobile. Now, as I mentioned before, this building is no longer in existence. It was demolished. We moved to the back part of this on the Salvation Army. This is the most recent location of the Birmingham Clinic in the Salvation Army in Carson and 9th Street. Now, this building is under renovation. And for the last 2 years during the pandemic, we have been providing services in UPMC Southside. I'm going to show you some pictures in a few minutes. But we go to the Birmingham Clinic the second Saturday of the month. We partner there with the program for healthcare for underserved populations, and we get community support from the University of Pittsburgh, from the Salvation Army, from American Board members. And the good news is that I mentioned that internal medicine was the first specialty, pediatrics the second one, after us, many other specialties and subspecialties joined. So ophthalmology, dermatology, cardiology, pulmonology, endocrinology, which is great because this is all free care for the community for uninsured patients. The one problem that we have is that the majority of those subspecialty clinics are provided by adult providers. And in some specialties, this is not a big issue. In terms of dermatology, ophthalmology, they can see pediatric patients and adult patients at the same time. But in the case, for example, of cardiology, our adult colleagues in internal medicine and in cardiology didn't feel comfortable seeing our pediatric patients. So over the last several years, we have been working, trying to develop these subspecialty pediatric clinics. And I'm happy to report today that one of the things that we have done over the last 2 to 3 years is open a pediatric ophthalmology clinic. And on that, I want to thank Dr. Matthew Pilblatt, one of our faculty here at Children's, and Dr. Evan Waxman, ophthalmologist at UPMC and at Mercy Hospital. And I'm going to show some slides about this in a few seconds. This is the temporary location of the Birmingham Clinic. As I mentioned before, it's in the south side. Some of you guys recognize this location because this is where the UPMC COVID-19 response center is. This is where the COVID-19 vaccines are in the south side, where the COVID testing is in the south side. They have lent us the first floor in the south tower. This is where the Birmingham Clinic is. And then we bring the care mobile. And then we have this picture of the tent. This is when in June of 2020, after being on isolation for many months, and then we start to reopen and we start using this tent to do vitals and to do vaccination. Now we have UV filters in the care mobile. And with those filters, we see all the patients inside the truck with no major problems. Now, I was mentioning the Pediatric Ophthalmology Clinic, and again, I want to thank Dr. Matthew Pilblatt, faculty at Children's Hospital Pittsburgh, pediatric ophthalmologist, and Dr. Evan Waxman. Dr. Waxman was the creator of the free ophthalmology clinic that goes to different locations, not only into Birmingham, but other locations around the area. But just a year or two ago, we started with this pediatric ophthalmology clinic. They only see kids, and it has been a very success. I have a story of a family who came from Venezuela. They had a teenager son who for many years had been seen by different providers. Nobody had seen anything. One of our residents decided to do an exam on this child and found that there was some abnormalities in the eye exam. Turned out to be a very interesting pathology, to the point that it was looking to publishing. This child needed surgery. The good news is that this family were able to get an immigration status and insurance. The dad got a job in Carnegie Mellon, and through the dad's insurance, the child, the teenager, got his eye surgery. And every time I see his family always thanking me about the service that we provide through the free clinic, to the Birmingham Clinic, to pediatric ophthalmology, because without us, they wouldn't have been able to solve this case. And we didn't even realize that the child had that problem. Again, for many years, the child was seen by other providers outside of the country. Nobody realized that they had a problem in the vision of the child. Now, I mentioned the care mobile. So the care mobile was donated to Children's Hospital of Pittsburgh in 2001 by Ronald McDonald Charities. We have had 2 care mobiles. This is the old care mobile, and then the new one was donated to us in 2019. And we take it to different places, once a month to the Birmingham Clinic, and once a week to Casa San Jose. I will show you some pictures in a few minutes. And the reason that we use the care mobile is to increase room availability, to track medical records. By the way, all the patients that we see in our care mobile, in the free clinics, you can have access of these records through Cerner in any location if the patient show up in the emergency department. And also important for us is vaccination. So thanks to the care mobile, to the staff of the care mobile, to Dr. Miller, we are able to provide immunizations to the kids. And this is through a vaccine for children's program. Now, this is our new unit. I make the reference for those of you who are from the last century about the gadget mobile. This is a truck that you press some buttons and has some pop-ups. Here you see on the left side of the picture how the truck pops up and increase availability. It's a state-of-the-art care mobile. This is some of the staff of Casa San Jose and the staff of the care mobile. We have a nurse, we have a driver. The drivers, by the way, are amazing. They do more than just driving the care mobile, which for me, that would be enough. I wouldn't be able to drive this huge truck. But, you know, right now this looks nice, but during the winter in the current environment, you know, they have sometimes to shovel snow. They have to clear the side roads. This is in Broadway Avenue where the T runs by. The city cleans the tracks of the T very well, but they don't do a good job with the sidewalks, with the side of the street where the care mobile is parked. This is where Casa Jose is. While the care mobile is ideal, if you ask me, my dream would be to have a brick and mortar location where we could see kids for free. We have to use the care mobile because it's the only free option to provide free care. And the care mobile is wonderful, but we have some limitations. For example, with these temperatures, we have limitations on the use of water because the pipes they freeze. So we have to use hand sanitizer or gallons with water to wash our hands. We cannot take the truck on every single temperature. There are some limitations on when the truck can go out, or how much snow, or how many wind. So there are some limitations, but we started before the pandemic doing a pilot project to demonstrate that we needed to have weekly clinics. I mentioned before, there are over the last 4 to 6 years, in particular with the previous administration, because changes were made, the number of uninsured patients, the number of kids who needed free care increased. We were doing it only once a month. So we did a pilot project with Dr. Ragavan and myself. We were going to the Birmingham Clinic. We were administering vaccines. Dr. Ragavan was afraid about giving the shot to the child. I was afraid about documenting correctly the child because of concerns of the numbers in the VFC. But with that, we were able to prove that we needed to have this weekly clinic, thanks to the support of the hospital, the department, our divisions, Dr. Miller, Dr. Hoverman. We now are able to have the care mobile on Tuesday clinics. And despite the pandemic, our numbers has increased over the last 2 years. And last year we saw the most patients without insurance, the most free care visits in the 20 years of the program. We do a lot of programs in the community. We organize community events and fairs. We promote healthy habits, distribute healthy information. We do advocacy. Many of you will recognize Roberto Ortiz, our triple board, who was with us for many years. Now he's in CHOP. Tina Ramirez, who was our nurse, she is now retired. We also have a program to increase physical activity with the community. This was an initiative of Dr. Reese and Dr. Marroquin's children to partner with the soccer team of the University of Pittsburgh. And the idea is that that we wanted to transmit to a community was that in order to be active, to be physically active, and to practice sports, you don't need to belong to a fancy league or pay for expensive uniforms or have expensive shoes. When I show this slide, I think Dr. Bogan pointed to this, she likes this, that you see the man playing in heels. So bottom line, what we want to tell the families is that in order to be active, you just need a field, a park, and a ball, and go out with your family and run after the ball. And that's the idea of this program, Fútbol para Niños, Fútbol para la Familia, soccer for the children, soccer for the family. Many of you know about the Pittsburgh Promise. The Pittsburgh Program is an amazing program that the Pittsburgh Public School has with a foundation that they provide grants, that they provide scholarships for teenagers who graduate from the Pittsburgh Public Schools to go to college. They can choose any college in the state, private college, Penn State, CMU, the University of Pittsburgh. The money that they get is as much as $40,000. In some point was now it's less, but in some point was as much as $40,000. UPMC has been a sponsor of this program, and this program was great. But the one thing that we realized is that all the information was in English. So I'm going to tell you in a few minutes what we did with the Pittsburgh Promise to make sure that the community were aware about this program. We put a lot of emphasis on literacy. So we have this literacy program since the beginning of our Salud Para Ninos. We provide books to kids 6 months and older every chapter visit. The books are bilingual. This was our all family collection. We have Isabel Angelelli, who is one of our faculty at Children. She's reading the stories to families and kids. We have our former literacy program director, Marianne Davis. And I like this because it's not only incentivizing early literacy in the kids, but also incentivize the parents to learn English. And while I believe that if you live in this country, you need to speak the language, it's really hard to speak the language. And you can see after many years of me, this is how far as you get in English. So it's not that easy. But these programs definitely help the community and help in terms of addressing education disparities. In terms of initiatives for healthcare education, we have college volunteers coming to our clinic. Right now, the volunteer program at Children's is in standby because of the pandemic. We have dental students from the Hispanic Student Dental Association. They still coming every clinic, and they help our patients with screenings, with referrals, with dental fluoride. We have law students. We have a legal medical partnership with the School of Law of the University of Pittsburgh. We have had social work interns and nursery students from different schools, Shadyside, Mercy, and Pitt. And in terms of medical education, we have an elective for medical Spanish that first and second year medical students can take. And then when they move to third and fourth year, they have a pediatric leadership rotation and elective on Latino health. It's a whole week where they work with me, go to the Kermobile, go to the Birmingham Clinic, go to Oakland. They now with the weekly clinics in the Kermobile, now we have a continuing clinic experience for pediatric residents. We have 3 residents now doing this for the last 2 years: Ursula Perling, Rachel Alade, and Jonah Collado Puello. If any of the residents listening to this presentation is interested, please reach out to the chiefs. They can help you to schedule your continuing clinic with me on Tuesday mornings. And the same thing for medical students. If you're interested, reach to Martin High for the elective. We also have had scholarly projects. People have submitted cash grants with our program. And then we have volunteer opportunities for medical students and residents. So let me share quickly some results of what we have done over the last 20 years. So we have enrolled over 1,400 children in our clinic, in our program. We're providing about 1,800 visits a year, both between insured and insured children. We're 6% of all the visits at the primary care center in Oakland. And we have assisted more than 150 children in obtaining health insurance. When they come to our clinic, we screen, we see whether they may or may not qualify for health insurance. And if they do, we help them to apply for health insurance. This is the old care mobile, how it looks inside the care mobile. We do a lot of programs in the community. I mentioned this before. We have done 7 CPR community classes with more than 200 people training CPR. We put a lot of emphasis in injury prevention programs, in particular in vehicle safety. Many of you recognize Chris Vitale, who's a great partner in the work that we have done over the many years. Since the summer of 2003, we have organized 26 Hispanic Latino car seat checks. We have checked 622 car seats at no cost to the families, and 309 of those car seats have been replaced. And over the years, we have been able to train bilingual, bicultural certified techs that do this program. When you do this preventive program, not always you can prove that there is benefit, that there is a result, but in 2005, there was this family, they were driving, it was a Mexican family who was driving this minivan. They were going through Shinley Park to the waterfront for Christmas shopping. The family was hit by this car. This car was running away from the police. Race shouldn't matter, but the people in the car were white. The driver was taken to the intensive care unit in Presby, and then he was charged with homicide because his passenger died. And then the Mexican family had come to our car seat checks. They're all well restrained. They were wearing the seat belts. They were in the car seats. The picture is not fair because it doesn't show the damage of the minivan. The minivan was total, but none of the kids or the adults in the minivan, they were 2 kids, 6 months, 4 and 5 years old. And then the 2 parents, none of them suffered any injuries. They were checked and they did well. But as I said before, the passenger on the car who was run away from the police died. They were unrestrained, the people in the white car. Now, with the Pittsburgh Promise, we reached to them, and thanks to the director of the Pittsburgh Promise, Salim Gubriel, the director, and at that time, the superintendent of the Pittsburgh Public Schools, Lynn Lane, we did 2 town hall meetings with the community where we taught the community about the importance of school. We taught about the difference between public schools versus private schools, what is a charter school, and then we told them about the Pittsburgh Promise. And again, thanks to Salim Gubriel, we were able to translate the materials into Spanish, and actually they use our patients for this picture. So these kids are our patients from Salud Para Ninos, not all of them, but many of them. And these are kids who have been benefiting from the Pittsburgh Promise, and many of them are first generation from graduated from high school and first generation who went into college. When people ask me, what is your goal of your program? The goal of my program is to make sure that kids grow up healthy, but they grow up healthy to be adults that give back to the community. So what a great way to do this to the Pittsburgh Promise, making sure that they go to college and that they become members of the community that can contribute. And then I'm going to show you a special example that is close to my heart. We partner with the family support centers. Many of you know what the family support centers are in Allegheny County, and in particular, the family support centers run by Children's Hospital of Pittsburgh, the Family Care Connections. This was our Family Care Connection that it was running in 2005 in South Oakland. And 2005, unfortunately, was demolished because they needed room for student dorms. This actually was the parking lot for the residents back when the hospital was in Oakland. So in 2007, we reached out the Department of Human Services in Allegheny County, Mark Cherna, and we asked them, can we have back again another family support center in Oakland that serves the Latino community? Now, my dream was that, and many of you have seen these slides where you have a dream, you introduce an idea, this is how the idea is enacted, this is how the mayor reported, and this is what you actually ended getting and what you ended needed. Similar to this, what happened with the Latino Family Support Center. What I needed was, or what I wanted was another family care connection run by Children's in Oakland. And I was not thinking that it was specific for the Latino community. What we ended up having was a Latino family center. Initially was in Square Hill, then it moved to the south side across our free clinic. And then the last location was in Hazelwood. Right now they're in terms of opening a new location. It was first run by the Allegheny County Intermediate Unit. This is the picture of the last location in Hazelwood. Now is run by the Latino Community Center. And I was talking about COVID. So when we started thinking about how we're going to address the disparities on COVID with the Latino community, one of the biggest points was that we need to address lack of information. So thanks to the support of UPMC, to Susan Baida, we did this town hall meeting with Dr. Ricardo Arbuluguerra, who actually is an infectious disease in Mercy Hospital. He's originally from Peru, and we did this webinar in Spanish, and we have an attendance of thousands of people asking questions about the pandemic. This was a month and a half into the pandemic, May 1st of 2020. And we have continued with many webinars in with many organizations. We have partnered with Casa San Jose, with the AIU Family and Immigrant Connections, with the Latino Community Center. This was an initiative from Dr. Mark Baratz, a hand specialist from UPMC, who decided to do what he called a double trade, which people donated money to a nonprofit organizations, in this case, Casa San Jose. So we donated money to Casa San Jose. The money went to local restaurants to make sure that the restaurants stay alive and stay open during the pandemic. And then they use that money to provide meals for members of the community. So we donated $500. They provide 100 lunches for members of the community. This is the Colombian spot. And this is the staff from Casa San Jose distributing those lunches. And then Casa San Jose had done an amazing job because many of the families didn't have that financial support from the federal government. They found ways to provide with some financial support, with groceries. We try not to have it at the same time. This day, we had the clinic in the morning, and then the people were lining up for the support. So you see them all clinic there in Casa San Jose. And then I was mentioning the importance of raising awareness about information. We have a monthly column in the newspaper. It used to be called La Jornada Latina, now La Mega Nota. Over the last 2 years, I've been writing in this column about COVID. Back in December of 2021, January 2021, I wrote the experience of Claudia Ardiles, who's one of our counselors at UPMC. She was one of the volunteers in Dr. Hoverman and Dr. Martin, the studies from Moderna and Pfizer. And she told the community in our column, the experience of being a volunteer in an immunization research study. And I think this helped to raise awareness and trust in the vaccine process for the community. And then last December, I showed the picture of my son 7-year-old getting his COVID vaccine at UPMC's outside and raising the importance about vaccinating our children against COVID. We reached to the health department and we asked them to come on Tuesday mornings to Casa San Jose and vaccinate our patients and vaccinate the parents of our patients on Tuesday mornings. And we also did a clinic in Oakland on Fridays afternoons where we vaccinated all the members of the community. So let me show you some results. This is vaccinations of COVID in the Latino community in Allegheny County. And at the beginning, we started slow. And I don't think this was necessarily hesitancy, this was access. Latino families couldn't take the time to stop going to work to get vaccinated. But once we make the vaccines available, we advertise no insurance, no cost, in your language, no appointments. People are coming to get vaccinated. And you can see how here the Hispanic community has surpassed the non-Hispanic community in terms of vaccination rates. And the same here is illustrated at the state level. 82% of all the people of all ethnicities in Allegheny County are vaccinated versus 80% of the Hispanic community, and the non-Hispanic community, 59% of one dose, fully covered 62% versus 50%. So in conclusion, there is a need for cultural and linguistic competent healthcare for Latino children. There is need for prevention and promotion, no need for new resources or services in most cases. Most services are in place and just need to be connected or adapted. And we have the need and the responsibility to advocate for those who cannot speak for themselves. We as pediatricians, we know that because we advocate for children. And for those of us who belong to minorities communities, we need to advocate for them because many of the minority communities, they don't have the voice to speak for themselves. So I want to thank all the people who have supported this program over the last 20 years, our department chair, Dr. Demori, my division chair, Dr. Hoverman, Dr. Miller, director of the community health, Dr. Bogan, our colleague in the primary care center and now director of the health department, Dr. Dina Hofkuch, who was the residency program director when I started the program, and the many attendings who have volunteered their time at Salud Para Ninos, Dr. Maya Ragavan, Justin Schreiber, Jen Welford, Dr. Reese, Evelyn, and Steve. They started with Dr. Marroquin, the Football Para Ninos program, the ophthalmology program, Dr. Matthew Filibat and Evan Waxman were working in the Pediatric Cardiology Clinic, and I want to thank the support of Dr. Kretzer and Dr. Laura Navarro, the staff from the Care Mobile, Sharon Hart, Rose Weiss, Brian Borges, Thomas Kemp. As I said before, our drivers do much than just driving the truck. They clean the snow. They take the groceries to the families when we have given them food for food insecurity. The staff of Casa San Jose, the executive director, Monica Ruiz, the founder of Casa San Jose, Sister Janice van der Neck, My colleagues and the faculty of the Primary Care Center and General Academic Pediatrics, our manager, Jamie Falconio, our operations manager, Karen Kohler, our nurse, Janice Fries, our bilingual patient representative, Melina Edelsack, and Ella Edelsack. And Melissa Castaño is one of the persons that I want to highlight because she was my patient. She was one of the students who benefit from the clinic and for the many programs local, and she's now one of our bilingual medical assistants. Our volunteer program, Amy Messick, the people from the Birmingham Clinic, Mary Herbert, Elizabeth Schwartz, Alison Barra, the techs, Chris Vitali, the Injury Prevention Program, the Allegheny County Health Department, the AIU, and of course the many schools at the University of Pittsburgh who have helped us throughout these years. And with that, I'm going to stop. I want to thank you for your attention.
Thank you, Diego, for just a tremendous presentation. And thank you so very much from all of us for all of your passion, work, dedication to taking care of the community. It is clearly shown what it is like to be a physician who is holistic and caring and part of our hospital. We're at time, and so I think we'll bounce from questions, but I do want to just quickly say in the chat, Diego, amazing, what people are saying, amazing presentation, so grateful for your work in advocacy, so grateful to your work. This is inspiring. You are inspiring many, many people, which is fabulous. I do want to say there was also in the chat, folks can look again, a link for folks working to help the population who need insurance. And so that link was put up by Daniel Weiner, and that's in the chat. So thank you once again, Diego, for all this incredible work that you're doing, and the vaccination rates speak for themselves. Incredible.
Thank you so much, Loretta.
Have a good day, all.